Welcome to my YouTube channel. Today we're going to talk about tocolysis. Kindly make sure you subscribe. It will cost you absolutely nothing. So before we talk about the role of tocolysis, let's look at what is tocolysis. Tocolysis is where you give a tocolytic agent, which we're going to look at them in the next slides, to prevent uterine contractions. And this mostly is usually given when a patient comes in with signs and symptoms of preterm labor. And what are the signs and symptoms of preterm labor? Preterm labor has very two key signs and symptoms, and the first one is uterine contraction, and the second one is usually cervical changes, which could be dilatation or effacement. I hope we are clear on that. So we give these tocolytic agents to prevent uterine contraction, therefore arresting preterm labor. So in terms of preterm, why do we give that? Why are we arresting? So we give. This is most commonly we give them in patients who come in and their pregnancy, the gestational pregnancy is it's less than 34 weeks. This is to allow administration of corticosteroids, which will enable lung maturity and prevent NEC, in addition to IVH. NEC is necrotizing and enterocolitis, and IVH is intraventricular hemorrhage. It also allows you to transfer the patient to a tertiary center where later they can deliver. In other cases, we use tocolysis or tocolytic agents during maternal and antenatal surgery, and so they are also used in uterine. They're also used to relax the uterine in external cephalic version. So the drugs that are used, or the uterine relaxants that are used, it's I've said this is just to prevent the contraction. So if you're not contracting, what are you doing? You're relaxing. So these uterine relaxants that are used, you can cram them by "It Is Not My Time." By I, it's indomethacin, which is an NSAID. N is nifedipine, which is a calcium blocker. M is magnesium sulfate. And then T is atabutine, which is adrenergic agonist. So the tocolytic agents, as we said, these are just a repetition plus now the dosage, which you can just write them or don't cram them. Don't cram them. As long as you know the tocolytic agents, then you're good to go. So the beta agonists, you can have tabitine. You can also have ditodrine, in addition magnesium sulfate, and the dose antiprostaglandin, which you can have indomethacin, and then calcium channel blockers, which you can have nifedipine and ditodrine. In addition to that, you can also have oxytocin antagonists and nitric oxide donors. Contraindications to tocolysis is when you have gestation more than 34 weeks, when you have significant vaginal bleeding, suspected fetal asphyxia, intra-amniotic infection, intrauterine demise or lethal anomaly, maternal indication, uncontrolled diabetes, severe anemia, cardiac disease, severe preeclampsia or eclampsia. Although the tocolysis may prolong pregnancy, they don't usually improve the prenatal outcomes, but do have adverse maternal effects. So these drugs usually have the normal side effects of our drugs, and what they'll adverse it to the mother. As a rule, they should be given with the corticosteroids, and most do not recommend use of tocolysis, as we said before, in pregnancies that are equal to 34 weeks or are greater than 34 weeks. And then there is no role of maintenance of tocolysis. These tocolysis have to be given within 48 hours.